Hello, this is Rebecca, and I'm going to give a supplemental lecture on Chapter 6, Nursing Care of Patients with Fluid, Electrolyte, and Acid-Base Imbalances. You guys did a really good job of presenting these in your groups in class, and so this is just a supplemental resource for you because fluids and electrolytes, especially acid bases, can be a little bit tricky. All right, so our outcomes are going to be identifying the purpose of electrolytes in the body and fluids. What are the signs and symptoms when they're imbalanced? We want to predict who are the patients that are highest risk. How do we collect data for those patients? Describe what are therapeutic measures. What are the educational needs of these patients? I want to categorize some of the common causes, signs and symptoms, treatments for different electrolytes. Identify foods that are going to have sodium, potassium, calcium, and then give examples of common causes of acidosis and alkalosis and compare how ABGs change when you have a different acid-base imbalance. So before we start really into some of the topic, we're going to go through this concept map. So if you want to read this slowly, go ahead and pause in between slides. I'm going to go ahead and read through. Mrs. Hernandez is a 62-year-old postmenopausal patient who visits her healthcare provider and reports shortness of breath and bone pain. She came to the United States 10 years ago with her husband. She has her own housekeeping business, but does not carry healthcare insurance. She does not use harsh chemicals in her business. Spanish is her primary language. The patient felt a palpable mass with right breast pain 6 months ago, but did not seek healthcare due to lack of insurance. She's never had any mammograms or breast cancer screening. Physical examination noted right breast skin, peau d'orange effect, which is when the skin gets really kind of like an orange peel, thick. It's kind of pitted and bumpy and thick. Excuse me. She had a mammogram and an ultrasound, noting a 6-centimeter mass with enlarged lymph nodes. Stereotactic breast biopsy was positive for intraductal breast cancer. Ms. Hernandez is visibly anxious and markedly short of breath. She has been nauseous and has a poor appetite. She is pale. You notice it's difficult for her to ambulate without holding onto the wall, and she seems to grimace with pain. She had her visit with the medical and surgical oncologist and is scheduled for a bilateral mastectomy, after which she will begin radiation and chemotherapy treatments. The oncologist recommended a lung biopsy, and Ms. Hernandez did not understand why she would need one. She doesn't understand English very well, and it's difficult to communicate with her. You have an interpreter present for your data collection. You ask her if she has any questions related to her diagnosis. In addition, you discuss cultural concerns that may come into play during her course of treatment. So this activity, we're going to start to put together a bit of a concept map. And we want to see how are those concepts related. If we were doing this in class, we would work in groups. And then afterwards, we'd add in her cues, nursing interventions, and collaborative relationships. So here is the beginning of this concept map. We have Mrs. Hernandez. These dark green circles talk about the nursing care that she needs or nursing concepts. So nutrition is identified as one. That's because she has nausea and vomiting. That's an assessment piece, right? What other things could we put in there? Well, I think about general assessment. What does her abdomen look like? Does she have bowel tones? What about her intake? What has it been? How much is she eating? How much is she drinking? You could also relate that to a digestive maybe issue and say, what's her output been? When's the last time she had a bowel movement? Over here, herself, there's cultural concerns. She's also Spanish as her primary speaker. You can see how that also, being a Spanish speaker or as her primary language, also is about health, is connected to health promotion. Why would that be connected to health promotion? We would have to make extra sure that she understands our instructions, discharge care, follow-up, because there's a language barrier there. So as you kind of build this concept map, we would be adding on more things. Here we have safety being an issue, a concern because of her mobility, right? We want to make sure that she is able to safely mobilize. You know, in the case study, it said she's gripping the wall as she walked. She needs support. So what kind of interventions would we be doing? Maybe giving her an assistive device like a cane or a walker, maybe making sure we're using a gait belt and walking with her. Does she have good fitting shoes, or is she using grip socks if she's not wearing shoes? I would say, you know, she's gripping the handles. Do we also need to make sure that her eyesight is okay? Is that why she's holding the wall, because she is weak, or is it because her eyesight? And all of our assessment pieces, we start putting on this concept map. Okay. So moving on, review question number 1. When we talk about body fluids, where are most of them found? Intracellular, interstitial, intravascular, or transcellular? And the correct answer is 1. So intracellular. This is a nice little pie chart that shows this bright blue or light blue that's where most of your fluid lies, in that intracellular space. We have our intravascular, so like in our blood, and look, it's really not that much. In fact, a lot more is in that interstitial fluid, kind of between the cells around there. So kind of interesting to see that breakdown. The control of fluid balance in our body, really, we have several pressure sensors throughout our body that kind of measure a lot of different things and will help adjust the fluid balance. And we also have antidiuretic hormone. Our body is really good at keeping things in balance. And it might fluctuate a little bit here and there, but our body has a really good regulatory system for most things, including fluid balance. When when fluid and electrolytes move, it's usually by active transport. There is calcium that is being picked up and moved through a transport somewhere, or you have passive transport, and that's more like diffusion, filtration, osmosis, right? Osmosis being higher concentration, diffusing down to or moving to a lower concentration. Tonicity is when we talk about, I like to think about it as concentration with IV fluids specifically. So when we talk about patients with fluid imbalances, a lot of time the corrective action or what we're going to be administering, part of their treatment plan will be IV fluids. And so when we give IV fluids, it's important that you know what is the tonicity, or I like to think of the concentration. So isotonic, that's the same osmolarity as blood. So I think of like same concentration, essentially, about the same. Something that is hypertonic, remember word building, hyper is high. Hypertonic is going to have an increased concentration or osmolarity than blood. And then conversely, hypotonic, remember hypo is low, that's going to be a lower concentration than the blood. This is a nice little picture that I found, and I'm posting this in the resources, and you can see there's several of these in the presentation. Right here, the top 5 fluids, and so they have NS, or 0.9% NaCl, or sodium chloride, or lactated ringers, sometimes that's called LR. These are isotonic. Down here, you have hypertonic, right? That's an increased concentration. That's why he's kind of heavier. And then there's hypotonic, lower concentration. That's why he's lighter. And so we would use some of these fluids depending on what kind of imbalance our patients have. So fluid gains and losses. When we look at our patients, usually it's pretty easy to see like our gains, right? How do we take fluid in, right? Well, we're probably eating and drinking it. When we talk about eating it, we want to make sure we're measuring appropriately. Something like a steak probably doesn't have a lot of fluid in it. However, if they're eating a soup, that has a lot of liquid in it. And so we want to be accounting for that. That's also going to include IV fluids, right? We're going to be measuring how much IV fluids go in. Now, when we talk about losses, there's some things that do make sense or common sense when you, or sensible, right? We can tell what they are. When somebody urinates, we can measure that. If they're having diarrhea, that's liquid, right? They're losing fluid. We can measure that and actually see how much fluid they're losing. That's what's called sensible losses. There's also insensible losses. I particularly use sweating as an example. If you have a patient with a high fever and they're just sweating and soaking through their gown and their bed sheets are damp from all of it, they're losing quite a bit of fluid with that sweating. Their body's trying to cool them down with that. But we can't really measure that, right? There's no way to say that patient sweated off 50 mils of sweat, right? It's not possible to measure that. So we call that insensible. That's an insensible loss. So that's how we measure kind of what goes in and out. Fluid imbalances, we have dehydration, right? Not enough fluid in you. And then you can also have too much fluid or fluid overload. So review question number 2, a 76-year-old patient with skin tenting and decreased urine output is most likely experiencing which fluid or electrolyte disorder? Hypernatremia, hypocalcemia, fluid excess, or dehydration? And think about it, which one you want to choose? It's 4, right? So it's dehydration. And that's because, let me go back up there. Remember skin tenting, and that's checking skin turgor. So usually we do that in the top of the hand, pinch it up. If you're pinching it up and it kind of stays tented, that's a pretty good sign of dehydration, as well as decreased urine output. There's not as much fluid in the body, so we're not going to be excreting as much of it. So a lot of the signs and symptoms here, you guys probably can relate to. Most people have probably been at least slightly dehydrated at some point in their life. Maybe you exercised too hard, or you were out long doing yard work, or just, something. And what do you feel like? Well, you usually feel thirsty, right? That's your body's signal saying, I need water, I need liquids, I'm getting too low. And then let's move to this low blood pressure. Our heart is a pump, and it's connected to all of our blood vessels through our body. And our blood vessels are pretty elastic, right? And so as the heart pumps, it's sending that blood through those elastic or kind of balloony vessels. Now, when we don't have as much, like think about it filled up, think about a pump, and then we'll just say water because sometimes it's macabre to think of blood, but we have a pump that is sending out water through these elastic vessels. If we don't have a lot of water or blood in there, it's going to have a lower pressure, right? Because there's a lower pressure, that pump has to go faster to get blood or fluid to pump to all the places it needs to go. So our heart rate is going to be rapid or fast. It's also going to be weak. So when we're measuring our pulse, this last week we talked about a bounding pulse being something that was like, you barely have to touch the skin and you're feeling it. That's a higher pressure. Weak pulse is like, wow, I really have a hard time kind of feeling it. That's because there's a lower pressure there. They're going to have dry skin, dry mucous membranes. A lot of times we look at the mouth, lips, they might be cracked, skin tenting, decreased urine output, right? If we don't have enough fluid in our body, then we're not going to be excreting it more because our body is wanting to conserve it. And then we also might have an increased temperature. Interventions. What are we going to do if somebody has low fluid volume? Well, the first thing we're going to do is just monitor, right? That's part of our assessment. What is their weight every day? We're going to monitor intake and output. We want to increase their oral intake of fluids. And we want to also treat underlying causes. If we know that somebody, I've seen patients who older ladies especially, they're worried about incontinence and finding a bathroom when they're out and about. And so they'll just choose not to drink. And so they come in and they're very dehydrated because they just didn't want to be incontinent. And so we can talk to patients about that and the risks of being dehydrated. We also want to use caution with elderly patients. I talked earlier about homeostasis, and our bodies kind of have this balance that we maintain. As we're younger, we can kind of manage greater shifts in that balance with fluid or electrolytes, as patients get older, their bodies don't tolerate as much of a balance. And they're at more risk of having symptoms and complications from fluid volume deficit or excess. All right, another review question. Which intervention should the nurse initiate for a patient with fluid excess? Select all that apply. So we know there's at least one, probably more than one question or answer. Monitor weight, place in Fowlers, administer IV fluids, encourage ambulation, restrict fluid and sodium. So take a minute and think what you would choose. Okay, the answer is 1, 2, 5. So we're going to monitor the weight. Absolutely. 2, place in a Fowler position. Yeah, we want to have them a little bit more upright. They have too much fluid that can back up actually into their lungs, make it more difficult to breathe. Sitting more upright is going to be a more comfortable position. And 5, restrict fluid and sodium. We don't want to be giving them extra fluids if they're already overloaded. And sodium has a relationship with fluids. Fluid will follow the sodium. So if you have somebody that's eating a lot of sodium, salt, especially, they tend to retain more fluid. And so we want to restrict often those patients who have too much fluid. We want to restrict their sodium intake so they don't become even more fluid overloaded. So signs and symptoms. This is going to be pretty much the opposite of what we saw with fluid hypovolemia or fluid deficit. They're going to have a bounding pulse, elevated pressure. Like we talked about, the heart is that pump and it's sending blood or fluid out through all those tubes. There's so much in there that pressure is building up. They might have some respiratory changes, edema or swelling. They're going to have increased urine output as long as they have functioning kidneys. The kidneys are going to be trying to get rid of more fluid. They're probably going to have some weight gain and eventually might develop some heart failure. Interventions. Well, the same thing as fluid deficit. We're going to monitor weight gain or monitor weight, monitor urine output, monitor I&O, sit them a little bit more upright, like this gal here in the picture. They might need oxygen, depending if it's really affecting their breathing. They might need some diuretics, and we're going to be restricting the fluid and sodium. I like this little picture because when we talk about our concentration of electrolytes or hemoglobin.
Going in a moment of prayer with the 2 verses of Psalm 23. The Lord is my shepherd.
Okay, sorry about that. We had a little interruption. So with this little infographic, you can see that he's saying this way to fluid volume deficit or dehydration. And it says, watch us go up as there's too little body fluid. So sodium, hematocrit, and it's a specific gravity. I like to think about a balloon. And we are putting in a specific amount of sodium, maybe hematocrit, and in that balloon, as you decrease the fluid in that balloon, we're still going to have the same amount of sodium. We're still going to have the same hematocrit in there, right? But because that balloon is smaller, it is more concentrated. Because of that, if we do a blood draw on somebody whose fluid volume is decreased, their sodium levels are going to go up. A lot of their electrolytes might look elevated. And it's not that they necessarily have too much of those electrolytes. It's that they're concentrated because they are dehydrated. On the other side, it says, watch us go down with too much body fluid. This way to fluid volume excess, right? So as we have that balloon, right? Let's say we have the original balloon. It's got sodium, your electrolytes, hematocrit. If you add more fluid and expand to a bigger balloon, but you still maintain the same amount of sodium in there, that sodium level, if we draw a blood level, is going to be much more diluted and be a lower level. It's not that the patient has maybe not enough sodium to meet the needs of their body. It's just because they have so much more fluid, it looks diluted. Here, this talks about hemodilution. with hemoglobin and hematocrit. And so anyway, it's just kind of an interesting infographic to look at. So again, that's in the resources for this week. So sodium imbalances. Hypo is low, so hyponatremia, sodium deficit. Hyper is high, so hypernatremia, sodium excess. Where do we get sodium? A lot of times it's in our diet, our food. Anything that's canned, pre-packaged, pre-prepared is generally, like fast food, that's generally going to have a lot of sodium in it. And so you can see where patients who have fluid volume excess, we really want to try to have them avoid those things and make sure they know how to read labels. Some foods that you think would be healthy foods might have enough, one serving might have your sodium intake that you need for the entire day. So we really want to make sure we're educating our patients about reading food labels and knowing where there is food, where there's sodium. So some of the signs and symptoms, it's going to be, if we do a lab value, 135 milliequivalents per liter or less. They're usually going to have a fluid issue, excess or deficit. We're probably going to have some mental status changes. With the hypo or hypernatremia with sodium imbalances, I think of neuro, like mental status changes, weakness. That's one of the common causes with sodium imbalances. You also might see some nausea and vomiting. Interventions, well, again, we're going to, just like the fluid, we're going to be monitoring weight, monitoring intake and output. We might be restricting fluids depending on what's going on with them. And then we might be giving diuretics or steroids. Hypernatremia, high, right? So that's greater than 145 milliequivalents per liter. They're probably going to be thirsty, right? Because usually with hypernatremia, a lot of times it's dehydration. It's just concentrated. They're going to have some mental status changes. If it really is getting fairly high, again, it's that neuro symptoms that they might have seizures, muscle weakness, the mental changes. And so that's why I associate neuro with natremia. So think sodium is hyper or hyponatremia. So the N, neuro is natremia. Interventions for hypernatremia, we want to treat what the fluid imbalance is. We're going to monitor their INO, monitor their weight. They might get diuretics depending on what the problem is that's causing the hypernatremia. We're going to restrict sodium, right? We don't want them adding more in and treating that cause. All right, another question. Which electrolyte is most critical to healthy cardiac rhythm? Is it calcium, sodium, potassium, or magnesium? Dun, 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 make your choice. Number 3, what was that? Potassium. Yeah, these all work together, especially I think of calcium and sodium. They do work with cardiac rhythms, but potassium is the one that is most critical to our cardiac rhythms. So with potassium, we have hypo. So hypo is low potassium, hypokalemia. Hyper is high, hyperkalemia is too much potassium. We can find potassium in our foods, sweet potatoes, green beans, yogurt, bananas, avocados, orange juice. Some of our prepackaged food might have an excess of potassium as well. So we just want to make sure that we're reading labels or we're educating our patients on reading labels to know how much they're taking in. Signs and symptoms for hypokalemia, so that's low. The level is lower than 3.5 milliequivalents per liter. They're usually going to have some muscle weakness, shallow respirations, mental status changes, and they might have cardiac arrhythmias and arrest because the effect that potassium level changes have on our heart. Interventions, we want to treat the underlying cause. What's causing us to lose the potassium? We want to give potassium-rich foods. We might want to give a potassium replacement. And we want to teach the patient signs and symptoms to report and how to give a potassium supplement. I think a lot of our heart failure patients receive medications like furosemide, or Lasix is another name. And that's a loop diuretic, meaning that it works in the loop of Henle in the kidney. And as it pulls fluid, or it stimulates the body in the kidney to pull more fluid and essentially urinate it out. So patients on a diuretic are going to be excreting more fluid by urinating it out. Now, specifically with furosemide or Lasix, these medications, they're going to pull fluid, but they're also going to pull some of the electrolytes as well, specifically potassium. They're going to be wasting the potassium, or it's called a potassium wasting diuretic. So anytime we have somebody on furosemide or Lasix, they should be on a potassium replacement, because we know that, yes, we're pulling the fluid, but we're also pulling this potassium that the patient needs as well. So we want to replace that. This little infographic, this guy's name is Walt, and he's a sick Walt. So with potassium deficits, you're going to have sick, shallow respirations, irritability, confusion, weakness, possible arrhythmias, lethargy, thready pulse. Kind of a weird looking guy. Practice tip from the NCLEX practice analysis. They want LPNs to be able to monitor intake and output and provide care for clients with fluid and electrolyte and imbalances. All right, let's do a little bit of cue recognition. We're visiting Mr. Anand at his home after his discharge from the hospital following a heart failure exacerbation. You note the following meds: digoxin, hydrochlorothiazide, and warfarin. And Mr. Anand is reporting weakness and fuzzy thinking. What action do you take? All right, so let's go back and read through what is going on. So we're visiting him at his home. So we're probably home health nurse after discharge from hospital following heart failure exacerbation. So what is an exacerbation? That's when you have a chronic condition that usually it's maintained. You do okay, but it can exacerbate or get worse. A lot of times I think about asthma. Patients with asthma usually can maintain, but then different things like getting a cold or flu, maybe environmental things like when we have our wildfires and all the smoke that's happening, that can exacerbate the asthma. And sometimes these patients will need to be hospitalized. So Mr. Anand had to be hospitalized for his heart failure. You note the following medications. Digoxin. So we know that digoxin is a medication for heart failure. It helps to slow and increase the strength of how the heart is pumping. Hydrochlorothiazide, that's a medication that's a diuretic. It's going to pull extra fluid out of his body. And warfarin. Warfarin is a blood thinner. So Mr. Anand is reporting weakness and fuzzy thinking. So what do you think that might be a sign of? All right. So weakness and fuzzy thinking could be a lot of electrolyte imbalances, but he's taking hydrochlorothiazide, which can pull, just like furosemide, it can pull some of that potassium from the body. So he might have some hypokalemia. So we're going to be collaborating with the case manager, the healthcare provider, and we're going to use SBAR. What might that look like? Oh, I guess I didn't do an SBAR. But we could say something like this: they're taking a medicine, that causes increased potassium. He's showing signs of low potassium. And we know that low potassium can cause serious cardiac arrhythmias. So we recommend that we do something, right? We maybe want to get a blood draw and just verify, is this low potassium? Might request for a order for potassium replacement. Hyperkalemia, over 5 milliequivalents per liter. A lot of times they might have some muscle twitching and cramps, diarrhea, low blood pressure, and again, cardiac arrhythmia and arrest. We're going to limit the dietary potassium for these patients. We're going to hold any potassium supplements, right? Because if their levels are too high, we don't want to give them any extra potassium. And then we're going to give them medicine as ordered. We might give them a diuretic that is a potassium losing or potassium wasting diuretic. Electrolyte is a medication that will pull potassium from the gastrointestinal tract. It does that by excreting it with diarrhea. So it's a wonderful medication that your patient will have diarrhea, but they're also going to be pulling that potassium through as well. Insulin with glucose. This specifically is given IV. Usually you're not going to give insulin IV outside of a patient with diabetic ketoacidosis. We'll go into that next term. Or another diabetic complication. But when we give insulin, insulin pulls glucose from the blood into the cells. It also is going to pull the potassium into the cells, and it will lower your blood level of potassium. Did I see that right? Yeah. But if we give somebody insulin IV, no, because we want it to pull the potassium into the cells, we know it's going to pull the glucose and it's going to drop their blood glucose level. So we're going to give them some IV glucose at the same time. Because we're not giving it to lower the blood sugar, the blood glucose level, we're just giving it so that we'll pull the potassium into the cells. Again, here's another little picture of hyperkalemia. He's got this muscle twitching, he's weak and anxious. Look at this low urine output, some cardiac changes. Now moving to calcium imbalances. Hypocalcemia, hypo is low. Hypercalcemia, hyper is high calcium level. So what are some good food sources of calcium? Oh man, I don't know what happened with this. Okay, I can't tell what number 1 is. Number 2, canned salmon. 3, spinach. 4, yogurt. And 5 is whole grains. Let's hope number 1 is not an answer. Oh, good. 2, 3, and 4. So canned meats like salmon, spinach, yogurt. Yeah, most dairy products have a lot of calcium in them. Whole grains. I feel like that was a trick question a little bit because whole grains do not have calcium, but fortified cereals, a lot of like breakfast cereals that you see will have, they're called fortified, and they've added in calcium to them. If they're whole grain cereal, that doesn't mean that they have added calcium. It's more that they are just have more fiber. But the fortified cereals will actually add in calcium. And you can see, like I said, a lot of the dairy products, yogurt, cheese, milk, those are all very high in calcium. Some of the hypocalcemia signs and symptoms, well, if we draw a blood level, it's going to be less than either 9 milligrams per deciliter or 4.5 milliequivalents per liter. It's whatever your facility that you're in, whatever system of measurement they use. You're going to have some mental status changes. You might have some ER. So hyperactive deep tendon reflexes, diarrhea, and they might have cardiac arrhythmia and rest because we know that calcium is an important electrolyte in our cardiac function. Hypocalcemia, I think the group did a really good job of showing when they presented Trousseau's and Schwab's sign. So Trousseau's, you get a blood pressure cuff. When you inflate it, you kind of have this cramping of your hand. And Schwab's tap on their cheek and you have this kind of twitching that happens. Sometimes you think, well, why is that important if we can just get a blood work draw? Well, you can't always get a blood work draw, right? You might not have access to it where you're at. And this is an assessment tool that we can use that might be able to confirm an electrolyte imbalance with our patients. Some interventions, we're going to treat the cause. We're going to have them increase how much calcium they take. They might even need supplemental administration of either IV replacement of calcium, oral, or sometimes they might have a phosphate binder that will help increase their calcium level. So on the other side, hypercalcemia. That's where calcium is greater than 11 milligrams per deciliter or 5 milliequivalents per liter. Again, you're going to use whatever the facility you're in, whatever unit of measurement they use. They're going to have increased heart rate and blood pressure, muscle weakness. They're going to have some decreased gastrointestinal mobility, which means they're going to tend towards more constipation and food's not going to be moving through as fast. Some interventions, we're probably going to be giving some fluids. We want to give medications depending on if they want to give a diuretic. These patients might even need dialysis to pull off this extra calcium. Moving on to magnesium imbalances, hypomagnesemia, low magnesium, hypermagnesemia, high magnesium. So that's hypo is less than 1.5 milliequivalents per liter. Just like in low calcium or hypocalcemia, they're going to have a positive Trousseau and Chvostek sign. Magnesium is important to our heart as well. So again, we might see cardiac arrhythmia or arrest. Interventions. With all of these, we want to treat the underlying cause. We might even give them some magnesium replacements. With a higher magnesium level, greater than 2.5 milliequivalents per liter, there might be some hypotension, lethargy, weakness, again, cardiac arrhythmia, and arrest. So interventions, we're probably going to be giving some IV fluid. We might give some medications, diuretics that might pull some of that magnesium out of their system. Again, they might even need dialysis to pull that out. All right, so acid and base imbalances. We're going to flip from electrolyte imbalances and move on to acid base. So again, when we talk about acid base balance, a lot of times we're looking at our body's pH level. Our body has a pretty tight window of where it wants to be in that pH balance. And there's so it really is a balance, because different things are going to cause us to tip one way or another, but our body has compensating mechanisms that help keep us pretty level right in that area that we like, that our body needs to be. So substances that are acidic, they release a hydrogen ion. Substances that are more basic or alkaline bind that hydrogen ion. Our normal pH is 7.35 to 7.45. Now, if you go lower towards 7.35 or less, that's more acidic. If you go higher, above 7.45, that's more alkaline. We have what are called buffers, where things that can help keep things in place. Our lungs and our kidneys are really good at adjusting different mechanisms to help keep our pH in a nice balance. A lot of times I think about our lungs. As we're breathing, we inhale and we get in all of the air, which has a lot of oxygen, and we exhale, we blow off a lot of that carbon dioxide. And so when we do that, we're blowing off. Oh, excuse me, one second. Okay, sorry about that. I thought my battery was going to die. So our lungs, we are breathing out carbon dioxide, right? And so I think about our acid and base imbalances. That carbon dioxide is more acidic. And so if we are blowing it off, we're breathing really fast, we are blowing off a lot of carbon dioxide, and we're probably going to be a little more alkaline or alkalosis from that. On the other side, if we have a patient who's not breathing very well, who's breathing very shallowly, not breathing very fast, only, under 10 a minute, not very fast, they're going to be retaining a lot of that CO2, and that's going to cause them to be more acidic. All right, moving through here, acidosis and alkalosis, they can both be respiratory or metabolic, whatever is kind of causing it. When you look at blood gases, ROME is kind of a nice thing to remember, ROME. So it means respiratory opposite, metabolic equal. And what that means, you can look at this table. When here you've got respiratory acidosis and respiratory alkalosis, and it goes over and shows you the pH level, the CO2 level, the HCO3 or bicarbonate. See how the pH and the CO2 and respiratory alkalosis are opposite? The pH is down while the carbon dioxide is up. And in alkalosis, the pH is up while the carbon dioxide is down. So that's respiratory is opposite. Where when you have metabolic acidosis, when your pH is down, your bicarbonate is also going to be down. Metabolic alkalosis, pH up, bicarbonate up. That means metabolic equal. We're really not going to go more into ABG interpretation. That would be more something that if you go on to get your RN, then they would want you to have more training on how to interpret the ABG values. Let's go into this case study. So Ms. Rodriguez, she was brought to the emergency room after collapsing while running a marathon. She had muscle cramps, weakness, nausea, and some confusion. Her temperature is 100.4, blood pressure 86/52, heart rate is 110, regular rate and rhythm. Her skin is warm, dry, and flushed. She's receiving an IV solution of normal saline and may have clear liquids is tolerated. You're preparing to give a handoff at the end of your shift. I want you to think about the important information that you would include in handoff. I'm not going to have you turn to your neighbor, but I want you just to think, what would you use for SBAR? So I'm going to go back up to this screen, go ahead and pause it, or pause the video now, and think about what you would use for your SBAR report. All right, so here's a suggested answer for SBAR. She's a 38-year-old female. She collapsed while running. Background, she talked about muscle cramps, weakness, nausea, some confusion. Assessment, her temperature is high, blood pressure is low, heart rate's high. Her respiratory rate's also a little bit high. She's warm and dry and flushed and currently getting IV fluids. Recommendation, continue with IV infusion and monitor vital signs. Reinforce adequate fluid intake at discharge. We're going to get her back up to a healthier level with her IV fluids, but she probably is also going to need to increase her oral intake of fluids for a while after discharge. Why do we think that she was dehydrated? Probably the marathon, right? High, intense energy. It doesn't say, I don't think it said what the weather was like, but a lot of times in places where the climate is warm and you have people just running these extensive, long athletic activities, they are sweating and they are losing a lot of fluid. They might be losing electrolytes too through that sweat. All right, that is the end. So I hope you enjoyed or learned something from this supplemental video. Look forward to seeing you guys in class again next week. We're talking about post-op and preoperative care.